Right. The focus of this chapter will be on pathophysiology of bleeding, assessment and management of bleeding and fluid resuscitation. We kind of touched on that in the previous chapter. The pathophysiology applies comprehensive knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Introduction. Bleeding can be one of the most time-sensitive conditions. Can be external and obvious or internal and hidden. It is the second most common cause of shock. It can cause weakness, shock, and death. Perfusion is the circulation of blood within an organ or tissue in adequate amounts. Emergency medical care is designed to help support the heart, the brain and spinal cord, the lungs, and the kidneys. These are the vital organs. These are organs that cannot go without proper perfusion for a very long time. Cardiac cycle. Repetitive pumping process begins with onset of cardiac muscle contraction and ends with beginning of the next contraction. We touched on preload when we covered shock, preload and afterload. Preload is the amount of blood returned to the heart to be pumped out. So it's the pressure that is built up inside of the heart when it fills with blood before it contracts. Afterload is the pressure in the aorta or the peripheral vascular resistance against which the left ventricle must pump blood. So when the left ventricle contracts and pushes blood into the aorta, and then the aorta pushes that blood into the other arteries, there is some constriction occurring in these vessels, and that creates a pressure that the blood must flow against. That's peripheral vascular resistance. Cardiac cycle is connected to bleeding and shock through its relationship to blood pressure. Delivery of oxygen to the tissues is dependent on adequate heart rate, stroke volume, hemoglobin levels, and the arterial oxygen saturation. Now let's look at the pathophysiology. Hemorrhage is a discharge of blood from the blood vessels. Bleeding can range from a nicked capillary to a severely spurting artery to a ruptured spleen. External bleeding can often be controlled with direct even pressure, pressure dressing, splints, hemostatic dressings, tourniquets, pressure bandage. External hemorrhaging, usually a result of a break in the skin. The extent or severity is often a function of the type of wound and the injured blood vessel types. So the type of bleeding that occurs will be dependent on whether it's a capillary, arterial vessel, or venous vessel. Internal hemorrhaging may appear in any portion of the body. Non-traumatic internal hemorrhage often occurs in cases of GI bleeding from the upper or lower GI tract, ruptured ectopic pregnancies, ruptured aneurysms, or other conditions. The mechanisms of injury for internal bleeding: falls, blast injuries, automobile or motorcycle crashes. The nature of illness for internal bleeding: common causes of non-traumatic internal bleeding include bleeding ulcers, bleeding from a colon, ruptured ectopic pregnancy, and aneurysm. Signs and symptoms that we want to look for: pain, swelling in the area of bleeding, bruising, hematoma. Other signs and symptoms: hematemesis, which is vomiting of blood; melena, blood in the stool; hematochezia is digestive blood, non-digestive blood. The first sign of hypovolemic shock, hypoperfusion, is generally a change in the mental status. So the first signs of shock is going to be the patient's mental status, declines or changes. Importance of bleeding. Substantial changes in vital signs occur for approximately 2 points. That's 1 liter of blood loss. Hemorrhagic shock results in inadequate perfusion and it can lead to death. Bleeding is serious if a significant MOI is present, poor general appearance of the patient, signs and symptoms of shock or hypoperfusion is present, if there is rapid blood loss or the bleeding that is occurring cannot be controlled. This is serious. Physiologic response to hemorrhaging. Bleeding tends to stop rather quickly in response to internal clotting mechanisms. Platelets plug the hole and seal the injured portions of the vessel. A number of medications can interfere with normal clotting. Anticoagulants, antiplatelets. A patient with hemophilia should be transported immediately. So this is a patient that cannot develop clots. They have an issue with developing clots. So minor injuries can lead to significant bleeding in these patients. The trauma triad of death. A combination of hypothermia, coagulopathy, and acidosis increases mortality in trauma patients. Coagulopathy can result in further hemorrhage because the clotting factors are being used up. Identify the conditions of hypothermia, coagulopathy, and acidosis in the setting of trauma and intervene where possible. Hypothermia, the body's inability to maintain normal operating temperatures. Patient assessment. Scene size up. After the scene is safe, take appropriate standard precautions for yourself and your crew. Blood will look different on different surfaces. Determine the nature of illness or the mechanism of injury, and then start to think about your index of suspicion. Consider the need for additional resources, such as ALS, Medevac. Primary survey, search for life-threatening bleeding, be aware of obvious signs of injury and distress. Perform a rapid full body scan of the patient, follow the X, A, B, C, D, E mnemonic. X meaning exsanguination or exsanguinating bleeding. Assess airway, breathing, circulation. Disability is the patient's level of consciousness or orientation. Exposure would be when you expose and do your rapid scan. Now, depending on the patient presentation, the level of consciousness can be the first thing that you assess, or it can be down the line. It depends on the patient presentation. Determine the patient's level of consciousness using the AVPU scale. Any internal bleeding must be treated promptly. Determine how fast the transport decision should be made and where the patient should be taken. Once you have completed your X, A, B, C, D, E, and you have addressed all your life threats at this point, you would know if your patient is a load and go or stay and play. What is your patient's GCS does the patient need a rapid scan or focus? So when you complete a primary survey, you should be able to answer all of those questions. If you cannot, you have not done a good primary survey. So again, once you have completed your primary survey, you should know what the patient's GCS is. You should know if it's a load and go patient or a stay and play. You should know if a rapid scan or focus is required. After you have completed your primary survey, the next phase is history taking. Patient talking to you, then you want to obtain information. Patient not talking to you, you look at the patient physical presentation. Sorry, you look at the patient presentation and obtain your vitals. So history taking, investigate the chief complaint and be alert for signs or symptoms of other injuries due to the MOI or NOI. Carefully assess the MOI in trauma patients. Gather information on the patient's chief complaint using the OPQRST mnemonic and obtain a sample history. The OPQRST mnemonic gives you information on the presenting illness or injury. Sample is broad. After history taking, the next phase is a secondary assessment. Uncover injuries or illness that may have been missed, record vital signs, complete a focus assessment of pain, and attach appropriate monitoring devices. So your appropriate monitoring devices would be you put the patient, put on a pulse ox, end-tidal CO2 capnography, put the patient on a cardiac monitor. Assess respiratory, cardiovascular, neurologic, and musculoskeletal systems. Obtain baseline vital signs. Use your monitoring device. Put the patient on a cardiac monitor. Monitor the pulse ox. Symmetry. Monitor end-tidal CO2 using capnography. That's the gold standard, capnography. After your secondary assessment, reassessment, assess the effectiveness of any intervention. In all cases of severe bleeding, obtain the patient vital signs every 5 minutes en route to the ED. Recognize, estimate, and report the amount of blood loss with internal bleeding. Describe the MOI/NOI and the signs and symptoms. Excuse me for 1 sec. Sorry about that. The noise outside was a bit distracting. External hemorrhaging. So emergency medical care. External hemorrhaging can be managed with direct pressure combined with pressure dressings and or splints. Use of a tourniquet is preferred if necessary. So it's not every external wound you're gonna slap on a tourniquet on the patient, but there are injuries where it might be necessary. Provide high flow oxygen and assist ventilation as needed. Apply a bulky dressing to stabilize any object protruding from the wound and create pressure dressing. For your tourniquets, useful if a patient has severe hemorrhaging from an extremity injury below the axilla or groin. Commercially available tourniquets exist. You have various types. You have the combat application tourniquet, special operation forces tactical tourniquet, ratcheting medical tourniquet, stretch wrap and tuck tourniquet. So various types. You can use a blood pressure cuff as a tourniquet. You can use triangular bandages and improvise to make a tourniquet as well. But you will be guided by your protocol and you must be very comfortable with applying a tourniquet on a patient before you can do it in the field. So you have to have a lot of practice. A tourniquet is typically released at the hospital. If a commercial tourniquet is not available, apply a tourniquet using a triangular bandage and a stick or rod. Splints. Ear splints can control the bleeding associated with severe soft tissue injuries. Rigid splints can help stabilize fractures. Traction splints stabilize isolated femur fractures. Hemostatic agents work by causing enhanced clot formation in wound site. It adheres to damaged tissues and either dehydrates the blood or undergoes a chemical reaction that stimulates the natural blood clotting cascades. And they're still experimenting with the best type of hemostatic agents. And they are also doing research on tranexamic acid. The pneumatic anti-shock garment, it's an inflatable device that covers the legs and abdomen. Now, rarely used, always follow local protocol. So basically it's a device that, think of it as a pressure cuff around the abdomen and the lower extremities that keeps blood going to the upper portion of the body. It's rarely used anymore because of the complications that are associated with it. You can do some reading on that. Hemorrhaging from nose, ears, and mouth can be caused by skull fracture, facial injuries, sinusitis, infection, nose drop use and abuse, dried or cracked nasal mucosa, high blood pressure, coagulation disorders, digital trauma. Internal hemorrhaging. Definitive care includes rapid transport to the ED. Treatment focuses on treatment of shock, minimizing movement of the injured part, and rapid transport. Ultrasonography may be used to locate bleeding. Give the patient nothing by mouth. Keep the patient warm. Monitor the serial vital signs. At least 3 sets of vital signs should be your goal if your patient is critical. That will give you a pretty good picture of whether or not your patient is trending up or trending down. Management of hemorrhagic shock. Focus on exsanguinating hemorrhage first. So if there's life-threatening bleeding present, deal with that first. Identify and try to stop any major bleeding and quickly evaluate the patient's hemodynamic status with a pulse check. Establish and maintain an open airway. Obtain IV access, and this will be the largest IV that can fit, IV catheter that can fit this particular patient. So obtain IV access at the scene only if transport of the patient is delayed. Most time, we're gonna push to get that IV access started in the back of the unit. Monitor the level of consciousness, pulse, and blood pressure. And as AEMTs, pay attention to the pulse pressure, which is the difference between the systolic and the diastolic, and the mean arterial pressure. These values will be important if you're going to give the patient fluids. And that would be the end of this chapter.